Thank you very much. I appreciate y'all all being here. This has been a real good year for me as a result of the device, and so this is pretty much a no-brainer for me to come and share the experiences that I've had with this. I think I've had several things during the course of my career that really made a big difference to me. The femoral nail was big when I first saw the first femoral nail and the impact it made from treating patients in spica casts and traction, which was a part of my residency until we started nailing femur. That was pretty dramatic. Probably that was the thing that led me into trauma. And then the cannulated screw made a big difference in my life just because I didn't have to use 6.5 screws anymore. And then in 2006, when the screws got long and went up to 180, that really opened up a whole other realm. And I've used the Ziehm image since the early 90s. When I worked in Seattle, this is for the days we were trying to figure out what's a good inlet, what's a good outlet, and I think we've come a long way. And I'm just going to go through some case examples of what we've learned over the last year and show you some videos and things like that. This is the team I work with. It's a really good team. I disclose I work with a really fun, happy, energetic, enthusiastic team. It's a very busy place, and I'm being paid for this talk. I have an educational plan, and we're going to just stick today to pelvic and acetabular and femoral head injuries. I'm not going to really get into necks and ankles and all the other applications of this device, but we're going to talk about some of the problems that we have briefly, and then we'll talk about some of the solutions and give you time to ask questions at the end. One of the hardest things as a surgeon and a physician, I think, is just admitting the problems that we have. And we all have common problems, and then we all have unique problems to our own practice or maybe to our own individual sets. The reduction, fixation, and even just sometimes the assessment and safety of acetabular fractures. You can see this is a case that was done by a professor of orthopedic surgery only about 6 months ago, and you can see that clearly they had some trouble along the way. There are things we can't control. We can't control our patients. We can't control their bone quality, their previous health, how big and fat they are, what surgeries they've had, whether they got infected, how violent the fracture was. We can't really control any of these things. But we can have some control over our institutional issues and the access and the team that we work with. And then the one thing that we can control is the equipment that we use. And I think the equipment is what we're going to focus on today. And I think if you have good equipment, then your abilities and your experiences and then your judgment all sort of follow one another and things get good for you. And I think you'll see some of the instances. Probably all of you can look at this AP pelvis, a three-dimensional surface rendered model of a patient, and you say, well, he's got a complete symphysis and a left SI joint and a right SI joint. It's not too bad. And everybody has a pretty good plan of how they'll manage this. Some may want to attack the posterior ring, some may want to attack the front, some may want to do other things. But one of the things that we all suffer with is this is a 45-year-old police officer in Houston, Texas, who was working a funeral and crashed his motorcycle. And this is a soft tissue envelope that really may change things. So I can't really change his injury and I can't change his body habits, but I can react to it with technology. So the solutions to the problems that we have, I think, are with intraoperative imaging. And you know that we usually use biplanar or multiplanar imaging for the pelvis, and it sort of tells us what we have and it demonstrates where things are. And as long as we can kind of correlate the osteology and the landmarks, the radiographic landmarks, and how we set the beam to be tangential to the surfaces we want to see, all of those things can make sense to us, and we can assess the reductions that we get, and we can help understand if our fixation is sound and where it is, and we can do a final check before we finish the operations. This device is the Ziehm rotating anode flat detector, the RFD 3D, and it's a little bit unique. It's a routine C-arm, and it's this device you see here. It's just a normal C-arm. But it goes through about a 165-degree arc, and then it's got a little bit of extra movement to it that gives it 180 degrees of rotation. And I think you'll see some of the images that come off of it are pretty impressive. So I've worked with it since August of last year, and I can tell you that this has made me a lot better surgeon, very candidly. It's really helped me understand what I'm doing, and it's made me, I think, a much better teacher as well. Maybe some of our residents and fellows would say that it's made me a little not as good, but I think it's made me a better teacher because I have so many more visuals now that I can use, and I can really correlate real time what's going on. And I'll just go through some of the things that it's helped me with over the past 14 months. Are y'all able to see this pretty well, or do you need the lights dim? Okay. Silence means you can see well. So this is just a patient, and I'm going to just sort of show you patients that I've taken care of over the past several months. This is just all technique. And so this is a 67-year-old man who was in a car wreck. He ran into an 18-wheeler going about 70 miles an hour, and you can see he's got a fracture dislocation. And you can see it's labeled post-reduction because our resident, who was very good in the emergency room, was able to feel that he could reduce this hip, but then as soon as he let go, he could feel that it wasn't staying reduced. This guy had a reducible but not a maintainable reduction of his left acetabulum. And you can see easily the red arrow marks his transverse limb, and the yellow arrow marks where his dome, what's left of his dome is, and then the blue marks where his posterior wall is displaced. And if you get a 3D CT scan, you can see the comminution of the posterior wall, the involvement of the wall, and you can see the posterior column component of the transverse. And then on the CT scan, this is his injury CT scan again. You can see the transverse by the red, the yellow marks the intact dome, and the blue, the upper wall, and you can see the impaction of the articular block into the posterior column, cancellous bone. And then you can look a little bit lower and see the lower wall as well. So he's got a reducible, but he's got a not very containable, and it's probably because that yellow arrow on the intact dome, this is like a broken golf tee, and there's just not much room of the tee left, and so the ball doesn't sit on the tee well. So we take him to the operating room fairly urgently. I like a prone Koper-Langenbeck, and you can do it however you like to do it. It doesn't matter to me how you do your operations, but this is just our patient, and so I'm just going to show you he's prone, and you can see his left foot there is exposed, and this is just a C-arm image, and we put him in place. I don't use fancy fracture tables, and I don't use intraoperative traction or any of that kind of stuff. We just sort of put him supine or prone. And you can see we get our imaging, and this is the fluoroscopy that we get, and you can see now his head is reduced. So I've got a bunch of preoperative imaging that's all dislocated. I've got this is what I got to make my plan off of, and now I've got sudden change. I have a reduced hip, I've got a head under the dome, and I don't know what's changed. And so I can use this device to understand more, and I can do a real-time assessment of what's going on. And so I'm going to let this video load here for a second, and then I'm just going to play the video. This is how the machine works, and so what I'm trying to do is understand where we are in space right now. And hold on. Let me go back. And this is just the machine spinning, and this is a tech we're around 3:30 in the afternoon, maybe 4 o'clock. My morning time tech is still there, and he likes to start with the machine this way, and you can see how it moves over, and then it goes to this extra little movement to give it the 180, gets it extra 15 degrees, and then it'll go around, and he's already done the AP check to make sure he's centered over the left acetabulum, and then he'll stop it here as it goes to the lateral just to make sure that the table height is right, and then once we make sure the table height is right, then he'll finish with his collision check. That's just the way it's collecting information to make sure it's not colliding with the patient or the table, and then it goes to the same spin, and I'll show you what it looks like in the operating room once it's sterile in a minute. And so what I can get from that now is I can get these images, and this is in the operating room, and this is just off my phone. The image that you get on the screen is better, and so now I can get this coronal reduced acetabulum, and I can see the impaction segments, and I can see the transverse limb, and I can see the posterior wall components, and I can see it on coronal, or I can see it on axial. And this is just me spinning it, holding my phone and scanning through the images. So basically, it gives you an intraoperative, real-time axial, sagittal, and coronal imaging, and just with that C-arm movement. And I can put these up in the operating room, and I can save these if I'd like to. These are just a now reduced hip, and so I've got a better idea of what the patient's current situation is rather than what it was when he was imaged in the radiology department with the dislocation. I can go and do my job. I can clamp the transverse, screw the transverse, wire the wall, plate the wall, fix the wall, and then I'm in the middle of the operation now, and I think I've done a good job, but I may want to check on how we did it. So now I'm going to pack the wound, shroud the patient, position the C-arm again, check the AP and lateral, do a collision check, do the spin, and then I'm going to scrub out and review the images myself. So just to reorient you, this is still the same patient. I've just moved with my camera. I've gotten out of the way a little bit, and I'm up by the head now, and I'm just looking at the Coker Langenbeck, and you can see he's prone, and that's the left side, and his feet are to your right and head to the left. And you got to make sure they've got good hemostasis, because we're going to shroud the patient. This is one of our interns, Elizabeth Davis and Steve Cherney, our fellow, and they're shrouding the patient with just 2 drapes that they're going to snap in the middle, and you'll see why in a second. Just to keep things sterile. Now, I like to just use a little small snap cap on the C-arm because it's cheap, but there's also other more inclusive C-arm drapes that go along with this thing to accommodate the movement if you want to use those, and I've tried those as well. I just like this technique better because I like to just peel it off and just start all over with another snap cap after we've done the spin. But you can imagine you need to have the patient's wound in a hemostatic way because you're not able to see what's going on under the drapes right now, and so I can see Casey Constant chuckling a little bit like, yeah, it makes me anxious too. For about the first 10 I did, I really wanted to hurry as fast as I could. But then if you just have the wound dry, you're fine. And then I usually do this myself, but Steve's doing it here because I'm filming it with my phone. And then this is just the movement of the machine. And so this is another afternoon tech. He likes to start it this way. And this is my original tech went home. This is my evening tech, and he does it a different way. And he starts with it at the extreme. And then this is about how long it takes. And Steve's going to drop that clamp and then go get out of the field. It just spins around. No big secret. But the excursion is different, and you can see how the way I have done it with the shrouding, the C-arm now is over the field, and in theory you say, well, that's not very sterile. That's why I'm going to peel the sheets off in a minute. And you can see the tech, he's going to guide it and make sure the sheets don't hang on it and stuff like that. And that's about it. And once it gets through doing its little shake and bake here to get the extra 15 degrees, then we're in pretty good shape. And then I can go over to the machine and I can wait for it to process. It takes about 45 seconds for it to process, or 30 seconds. And then I can just see, this is just me filming with my camera again. You can adjust the contrast. And after we're finished, you can go over to the machine and play with it if you want to. But this just, I can check the quality of my reduction. I can check my implants. I can make sure that they're applied to the surface of the bone where I want them. And I can check to make sure all of my screws are contained. Just makes things very reliable. It takes about 10 minutes. And then I have these images post-op, and this is what they look like from the intraoperative Ziehm 3D. And then this is what the post-op CT looks like. So you can say, well, the post-op CT's got a lot more quality. I'm really comfortable with this in the operating room. I'm not sure as time goes on if I'll keep getting post-op CT scans, but this technology has really been a game changer for me. You can still see our wound is packed, you see the air in the wound. We can do this before we close the wound. We peel off the shroud and then wash the wound and close the wound. So it takes about a minute to make sure the bone has stopped bleeding, pack the wound. It takes about a minute to put the sheets on. It takes about 2 minutes for the tech to get the C-arm in position, check the AP and lateral images, do a collision check, and then it takes the spin about 45 seconds. And then I scrub out. It takes me about 2 minutes to close. So it's about 6 to 8 minutes total. But again, we do it a lot, and it's pretty much a routine, and so it just doesn't waste a lot of time. The radiation exposure for this patient, this is just our patient that we just did, and it's 182 milligrays. And so you can also see that, Johnny, are you still here?
Yes, back here.
Can you just tell them like how many images it gets per second and stuff like that?
It acquires 400 images and then reconstructs those images in about 45 to 50 seconds.
So it's 10 images per second. It takes about 40 seconds. And how long does it process them?
It takes 45 seconds to do the spin. And now keep in mind, that equates to only 9 seconds of fluoro time. And the reason that is because the generator is in the pulse mode, pulse fluoro mode. So it equates to only 9 seconds of fluoro time.
So you can see our total fluoro time for this operation is 41 seconds. 41.
How many rats is this? 180.
I told you someone was going to ask how many rats. And so it's 182 milligrays, which is equivalent to what?
I don't know the number again. There's an equation that thing came up to.
What's it equivalent to as far as like a chest x-ray or an AP pelvis?
the chest x-ray is probably going to be about 8 milligrays just for a standard.
How
Two
many-
Ds, 2 DM.
How much is yours in this on a routine operation? How many milligrays do you use for yours at the end of an operation on an acetabulum? When you go and check the radiation exposure, what does it say?
We check the
Tell
seconds.
the truth.
Seconds,
I
not.
appreciate that, but how much milligrays?
I know.
Does anybody know what their average milligray is? I don't think anybody does.
What's the volume that you're scanning?
What do you mean?
Was it a 10 centimeter by 10 centimeter?
We just center on the hip, and so you can put it to where it'll gather as much as you want. So like if we want to see iliosacral screws, we focus on the screws. If we want to see the hip, we focus on the hip. Go ahead.
The detector is a 30 by 30 centimeter, so for 2D imaging, it can acquire that field of view. For 3D, it's a 16 centimeter by 16 centimeter.
I think if you look at your fluoro time for your operations, you may find that your fluoro time is more than this. Yes?
Chip, you're using the same devices you're doing real time, you're looking at your column screw bed.
Yeah, I'm going to show you in just a second, we're going to go into another case as soon as we sort of clear this up, and I'm going to just show you some of the other just routine stuff. All of the images you've seen so far are off this machine. I just want to put a really important comment about this. We have 6 X-ray techs that we work with a lot, sort of 3 or 4 during the day, and then a couple in the evenings. And all of these people have done a really great job of learning this. This was early on. Nobody likes change, and they were biting at the bit a little bit. And then once they saw the images that they got off of it, it was like giving them a dose of heroin. They became addicted to the technology because they realized the images that they're getting and how it has an impact. So I'd just be patient with your techs if you're using this technology. They realize the impact that they have on patient care, and now they went from biting the bit to leading the charge. This is another example, David, just to show you how it can be used. This is just another both column. I sort of stuck with the both column mode here, and this is a patient from about 2 months ago. And he's just got nice, clean fracture, and that's why I chose him to show you. He's just got a nice, clumpy components to his fracture. This is his pre-op CT scan, and this is his CT 3D surface rendered, and you can see this is his intraoperative image. And so this is just him in the operating room, supine on the bed before we start to make sure that nothing's changed. You can ghost him in if you'd like to sort of help that. And then the way we used it for this guy is we went ahead and did the reduction and did the fixation, and you can see that he's still got a little crack, and if the little cracks like that bother you, you can check to see if your reduction is good. And so we did a spin on him once we did it just to see what the reduction was like. And so even though I don't like little seams, I'm not sure if I take this all apart that I can make this a whole lot better. So I'm pretty good with this reduction. So it's good for assessing your reduction as well as your screw safety. And I just thought this was pretty interesting as well. That's the intraoperative image on your left. That's just a screening AP at the end of the operation. And then the thing that you see with the staples, that's the post-op film. That's the digital radiology. And I think the intraoperative AP is better than the post-operative one. You can argue and say, well, you got drains in the way and stuff like that, but I didn't process these with Photoshop. These aren't like fabricated. Anyway, the imaging is, to answer your question, I think the imaging is quite good. And then you can see what I got in the operating room, the intraop Ziehm axial cut of the dome, and then the post-op CT scan, just to see the quality of the comparison of the 2 images. Another example, a lot of you have these kinds of patients. This is an incomplete anterior column associated bone column pattern, but when you roll him around, he's got this wall component as well, this fairly large wall component that some bone column fractures have. This is a 65-year-old guy, and you can see the asterisk is on the posterior wall dome component. And so this is, again, him supine in the operating room before we start, and then we put his columns back together. And then when we roll him up in the operator oblique, you can see his wall is still displaced. So some of you may say, well, I just leave it alone, it's not a big deal, or I clamp it percutaneously and put some screws in, or I would do another approach, or you did the wrong approach to begin with. I don't really want to argue all that. I'll just tell you how it really helped me on this patient. You probably know what's coming. So I clamped this posterior wall just around the corner. I just put a clamp around and crushed it. And then I put screws into the wall like I've done for a long time, where I thought the wall fragment would be based on a pretty good pre-op plan. And I can't give you much better 3D imaging than that. That gives me a really good idea of where I need to hit this wall in order to put screws in it to hold it and to keep the reduction that I have. and you know it's coming, and this is what it looked like before, and then here I am this is my first spin, and I've missed the wall fragment with my screws. And so I put screws in, but I didn't hit the wall. I didn't try to do this, just missed it. And so I can take those screws out and reclamp. I can reclamp the wall, take the screws out, aim them better, and then spin them again and see that I can hit it. So that, yeah, when these operations were going on, I wasn't invited to give this talk. And so like, this is just like, oh, that's a good one. So I think this is a good example of how the technology helped this patient a lot. Have screws where they needed to be instead of screws where I thought they were. And if you don't get post-op CT scans, you probably don't know where your screws really are. The other thing it's good for is loose bodies. You know, you may think that you've gotten all the loose bodies out of the fossa or the loose bodies out of the dome or the debris out of the joint that you wanted, and you can do an assessment to see if you really did as good as you wanted to do and if there's still debris in the joint that you missed. And then I use it, George Russell is here, yeah? This is, I'm an immensivist like you. I love the immense patients as well, and you can tell this is an immense patient, and again, I just use the red, blue, yellow, and this is her scanogram, and so she's reducible. Well, welcome to my world. And so she's dislocated, and then she's reduced here, you can see just with some traction. So we use it on the great big patients. And I'll just give you a pop test. See if you can identify this fold. Anybody know what this is? Yeah. Who thinks it's a buttock? Who thinks it's the buttock? Who's not going to vote? Let's start with it. Who's not going to vote? Okay, everybody's going to vote. So who thinks it's the buttock? It's the gluteal cleft. Okay, we've got a couple. Okay, who thinks it's where her belly meets her thigh? A couple more. Who thinks it's where her thigh meets her leg, her knee area? Okay? And who thinks it's where her breast hits her chest? Who thinks it's the axilla up against the chest? All right, so everybody stay tuned. This is just her belly on her thigh. This is her anterior, she's prone, and it's just this area right here. So I can do a poker lightning back on this woman. She's got some version of a T fracture. And maybe I can do whatever I want to do, but I did a patient just about 4 weeks before her that was just as immense as her, and you know exactly what this patient got. She has a beautiful x-ray, but she's got a terrible wound. And so for the lady that I just showed you, I just went ahead and made some little stab wounds and used some lag screws to hold her T component and just treat her like that to avoid the infection risk. And then you can see I can use the spin to assess my reduction. If this is no good and I can convert to open, then I got a reason to convert to open. But it just helps me. I'm not much on percutaneous fixation of acetabular fractures, but I'm really not so much on this either. And I don't know if you've ever had patients like this, but if you haven't, just keep working. Any questions about the sockets, the hip socket, the acetabular fractures? I think it's really good for femoral heads as well. Femoral head is a girl that was visiting Texas from California, and she inadvertently got into a wreck, and you can see she's got a fracture dislocation of the femoral head. She's got the reduction here, you can see, and then you can see her intraoperative film once we get started. Again, David, this is the same images. These are just the same images off the fluoro. And we do an ORIF, but then we can do a spin to check before we close the wound to make sure that we didn't leave debris or we didn't miss debris. This is just an anterior surgical dislocation of the hip through a Smith-Peterson or an anterior interval. And you can see we just use screw fixation to fix it. But I can also make sure that I didn't put the screws too long, malreduce the head, whatever. This was a pretty interesting patient that I was on a Sunday. This is a guy who works for the University of Houston. They're having a really good football year, so he's a pretty happy guy. Worked for the University of Houston for a long time. He's a young guy, maybe 42, and he's got bilateral hip fracture dislocations. His left side's a real peripheral posterior wall. Maybe you can see the fracture fragment. And then his right side's a femoral head fracture that's fairly low. You can see the orientation of the femoral head fracture. And so he had a closed reduction on the left that was very successful, and the closed reduction on the right was not successful. This is about his third attempt, and the resident that was doing it just said, I can't get it to go back in. So he had a presumed irreducible, he had appropriate sedation the whole bit. So we sort of prioritized him to the operating room to do a fairly urgent ORIF. He was fairly ill and had an angiogram on the way. And then we put him to sleep on the operating table, and when he was asleep on the operating table, his legs looked pretty good. In fact, His legs didn't look like they had any asymmetry at all. When I rolled his hip a little bit, it felt good. Somewhere along the way, he had spontaneous reduction of his right hip. So this was his left side, this peripheral posterior wall. So we can spin this. I can do an exam of this, and I can realize this is a very stable hip. The wall's not too displaced. I don't need to operate on this. Now I go to the right side because I think I'm going to have to do an open reduction of this hip because it's stuck and all of a sudden it's not. So I can just proceed and go ahead and operate on this guy, or I can spin him, and when I spin him I can see what his femoral head looks like. I can see the little bit of debris in the back of the joint. I can see there's no debris in the dome, there's no debris in the fossa. I can examine his hip through a full passive range of motion. He's got a very stable hip. I look at the scrub nurse and say, I'm very sorry you've opened all this stuff. I've made a huge mistake and y'all can go home now. Sorry. And so we wasted some money opening gear, but we didn't do a surgery that the guy didn't need. He spent 6 weeks in the chair, and he's celebrating with his favorite football team these days. So I think it has impact on sometimes changing your operative plan. I'm not sure I would have done that if I wouldn't have been able to assess that reduction. Maybe I would have sent him back and then come back another day, but this keeps me from having to do that. Binders are a problem. They're great. Or sheet wraps, they're great because they give you great reductions of the pelvic ring. And this is a patient I treated about 5-6 weeks ago. This is not a very good person, but she's in a binder. She's got an open forearm fracture. One of my partners is going to do her forearm fracture. And this is her film in a binder. She complained of pelvic pain, and they saw a ramus fracture. They put her in a sheet. And these are all the films that I showed, or I saw on her. This is her inlet and her outlet imaging in the binder, in the sheet. And then they got through with her forearm, and they took her binder off, and they called and said, can you come here for a minute? And so she's asleep in the operating room. They've taken the binder off, and she's got a complete sacroiliac joint injury that was masked by this binder film. So she's consented for pelvic fixation because she had a ramus fracture, so her consent allows me to operate on her if I want to. And so we put some traction in on her to see if that'll help. And so we get a pretty good reduction. We go from here to here. The traction is off, the traction is on, the traction is off, the traction is on. Okay? Everything's looking pretty good. Looks like it's a distracted SI joint. And on the outlet image, this is her in traction. Looks pretty good. So we decided to spin her. And this is what her spin looks like. So these are her images, inlet, outlet on top, and then this is her S1 and S2. And even though it looks really good on the inlet outlets, it's not really good inside. And if you haven't seen this before, I think most people who have a lot of experience doing pelvic, we've all got these cases. In fact, it would seem like you could just sort of do a screw like this and everything would be good. This is a patient that I learned this on 6 years ago, where I sort of thought I had a really good reduction. Looked just like this woman's. I put some screws in there, and then I realized that things weren't so hot after all. But now I've got this thing, and so I can see that she has this problem, and so we just convert to open reduction. We clamp it. Now all of a sudden her left SI joint shows that it also has some injury to it, and then we can proceed on and fix her. Anyway, not so obvious injury. Same with this guy. This guy is really sick. He's got a acetabular injury on the right side, and he's got not much of a sacral fracture on his right side as well, transforaminal sacral fracture. Looks pretty good, but again, he's in a binder. All of his imaging is done in a binder. And as soon as we take him to the operating room, that's his image in a binder. As soon as we take him to the operating room, it looks like this. And it's like, oh, this is not so good. And so we spin him, and that's what it looks like in the operating room. And so what used to be here in the binder is here. Anyway, you can decide what you want to do, and you can check and see if you did a good job using screws to reduce it, and then you can check it on the CT afterwards if you want to. But you can see his bilateral hemopneumothoraces and things like that. Anyway, again, a great tool to make a diagnosis of real-time things that might have been shielded by or veiled by the binder. This is another patient that had a car wreck, and he's 42 and has an intraperitoneal bladder disruption. They think he has a bowel injury, and so I coordinated with Dr. Cotton on a Saturday morning. Dr. Aker called me and asked me if I wanted to come work, and he was doing about 50 things, and so I said, yep. And so I worked with Dr. Cotton, and you can see they ran the bowel and fixed the bowel and fixed the bladder. And then they got through and left, and then they left me alone with this. And so then I can fix his pubis through their low laparotomy wound where they were fixing his bladder. And then you can see the SI joint looks pretty good on this view. Looks pretty inviting on this view. And so we just use a screw reduction technique for this guy. He's a little bit sick for going at it, and then we can supplement it. And in the operating room, I can see if I got a good reduction, if my screws are good or not. I'm all done with this guy. So I lost my Saturday morning, but I don't really care because I'm going to get my Monday afternoon. So however you want to look at it. I just know that I have a nice reduction and I have a good screw fixation, and I'm all done with him. This is a much sicker guy. You can see he's got a long line in his right groin, and we were trying to help him by stabilizing his ring. And if you look at that transiliac transsacral screw, you guys with the ladies with a good keen eye, you can see it's a little bit ascending. You can see it's ascending. And the S2 wire looks pretty good, but on the inlet view, you can see the S2 wire looks maybe like it's a little bit too posterior. So we went ahead and spun him while we had the wire in this position because it doesn't look good. And of course his wire is almost in his canal, if not in his canal. This is his second sacral segment wire. That's this wire that's right there. Looks pretty good on that view. It looks a little posterior on that view. For sure it is. So I can go ahead and then I can look up and you can see my screw that was ascending, it's out the other ilium. And I've done about, 8,000 iliosacral screws. I don't know how many I've done, but I was never able to tell if I had screws extruded like this except on a post-op CT scan, which a lot of people don't even get. For me, this is a really good thing, and I think it would be for all clinicians to know. So we can just adjust the screw, put it in. We can change that screw by using the bent guide technique, and then now we've got safe implants. I think this is a good thing as well. I'm not going to get into Ramus screws because a lot of people don't use Ramus screws, but if you do, and you'll have problems with those, this is good for those as well. This can be with acetabular fractures or with ring injuries. And then I just want to finish with this lady I did yesterday morning because she's a really good example, and I always hate to say, well, I just did this operation yesterday, let me show you about it, but look at her greater notch. If you look at her greater notch, she was crushed by a horse in my hometown about 60 miles from Houston, and she lives real near where I grew up, and she's a very, very active equestrian, and you can see she's got a complete symphysis disruption, and she's got a very comminuted iliac fracture that goes from iliac crest to greater sciatic notch, and her notch looks like it's quite disturbed, and you can see that she had an iliac artery injury and a superior gluteal artery injury. So they stented her iliac and they've embolized the superior gluteal. And you can see the proximity of the coil to that fragment, the greater notch fragment. The greater notch fragment is turned 90 degrees and 90 degrees. Anyway, this is the combination of her ilium. And so we did not want to get it. I really didn't want to get into this potential bleeding zone. I think it's great when the angiographers control the artery. I just remember from anatomy there's a vein there as well. And I've had experiences where I pull away a hematoma early on, and the reason there's a big ass hematoma there is because there's a hole in the vein, and that this is a deep zone for me at this point to stay away from. This is her CT, and that's the proximity of that blade on the gluteal, at least the artery. This is the embolic coil. So we just fixed her symphysis from the front, and then we use screws to just span this area of the ilium in the back. And I can use the spin. If you've ever had experience with these screws and you get post-op CT scans, you can realize that sometimes where you thought they were is not where they really are. And so this allows me to check in the operating room to make sure that the screws are where I want them to be and they're not in the sacrum or sticking out the back of the ilium, and that we're all done with her. So our educational plan was to go over some pelvis cases and to go over some acetabular examples and some femoral head fractures. I think we all know the problems that we have that we don't have control over. I think we do know what we can have control over, and one of the solutions, I think, to some of the problems that we have taking care of these patients is to this thing. You know, I've never cheerleaded much for a device, but I think this is a little bit of a no-brainer. Anyway, that was our deal, and so I think this, at least for 14 months, this has had a pretty dramatic impact on the quality of the care that I delivered. It's certainly made me, I think, a better surgeon, a better teacher. I can make real-time diagnosis. I can adjust my plans, whether it's to keep operating or not operate. It gives me real-time information. I think the quality of images is quite good, and I think it also has driven me to be a much better reducer, because I'm going to get revealed straight away. And then I think the implant safety, that's why I showed you that posterior wall one. So I think it's time well spent. And you say, well, what's 10 minutes worth in the operating room? I don't know. You can ask your OR but I mean, just sometimes watch how long it takes an anesthesiologist to put your patient to sleep while they're in the operating room, and that's 10 minutes too. So I just think it gives me a lot of information. That's all I have. If you have questions, I'm happy to take questions. They have a demo over there of a spine that you can mess with the contrast and the clarity of it and see how it spins. Yes, and
I have three questions. The first would be, how far you have to move at the side, how much is really scattering the radiation. You do have apron, you protect yourself as well, I guess. How much do you go back? Could you stay in the same room?
I'm a radiation phobic kind of guy. And so when I turn this machine on, or we're doing it, I have the medical student if there's one, or the resident if there's one. Just like when I said Steve was holding the clamps, and I do that myself. And then as soon as it comes to level, I just go stand in the corner. A lot of times they'll bring a shield in for people to stand behind. So we protect ourselves, but I think if you'll start looking at your fluoro time, one of the things that most people don't know is how many milligrays they have after a regular case. How much do you have? And I think you'll find that this doesn't really add a lot more. It's like, that's why you're getting 9 seconds of exposure during 40 seconds of spin because of the pulsed image. So it seems like it's a lot of images, it's just not a lot of radiation.
We were told that patient could get 5,000 rads per year. How much this machine, when you do it 3 times or 2 times, how much rads is that? Give me some orientation.
It was 180 milligrays, but it's 18 rads.
18 rads.
Yeah.
That's fantastic.
So we have a radiation safety department at our hospital, like a lot of hospitals do. And when this came in, you could imagine how they literally got like, they were about to attack. And I've heard not from them yet.
We have ORs, neurosurgeons use it all the time. They come out whenever they are spinning it.
I think that's a whole different, it's like saying apples and oranges. This is a whole different technology.
Second question, could we connect navigation with this?
Yes.
Yes, we are currently, we're open architecture for navigation. We currently have integration into BrainLab and to Stryker, and working with Medtronic. So we'll work with all 3 navigation components.
Great. The third one is how much does it cost in average hospital machine?
The system is $495,000. If you want this vascular package, it's $545,000.
So that's a really important point as well. And I don't know anything about the vascular, and can you just make a comment about that? Because it may not be just you that wants to use it.
Right. I think when you look at that dollar figure, if you compare that to a regular C-arm, obviously it's more expensive, but this is much more than just a C-arm. It can take 2D images as well, but also really the 3D component is really what separates it. So the 3 areas of really driving utilization in hospitals we see, and today we have about 50 units installed here in the United States, probably another 100 in Europe. But trauma, spine, and vascular, 2D vascular. So, in a trauma case, you could use all 3 of those specialties for the device. So
I don't know how much it costs when the patient has a posterior wall that really doesn't have the screws in it, and then they displace, and then they come after you for that, or they have to have another surgery, and you have to go say, "Oh, I'm so sorry. These screws, lo siento mucho, I've missed," and then they say, "Why don't you get someone who can do the job?" And so this keeps me out of doing surgeries that I didn't need to do, like for the guy with the femoral head. This keeps me doing surgeries that need to be done rather than just cramming in some screws and then getting going, oh my God, it's not even close on the moment we convert it to open. I mean, I've just tried to show you some examples of, I think, some very cost-saving moves that happened. Maybe we didn't amplify that when we were talking about it, but when I didn't operate on that guy, we saved some money. When I did the right operation and I adjusted things, I didn't have to have this talk with this patient about missing the screws. He doesn't even know that there were some screws here and now there's some screws there 10 minutes later.
Is there a reimbursement code for that? Is there a reimbursement?
No, it's part of the DRG for the surgery.
You had a question.
Yes, thank you for your presentation. We've
You're
been working with the same system for about 1.5 years now, and we're very happy with it. It changed quite a lot of procedures for us, although it takes a little bit longer.
Do you have any disclosures?
No, not at all.
Well, I think if we're cheerleading again.
Here it comes. There's one big challenge still, I think. When you go from posterior screw fixation, then we find it at least still very difficult because of the relative high amount of material in the small bone posterior to have adequate visualization of the gramina.
So-
There's so much scattering that very often I'm not sure what.
So do you know the solution? The solution is not to go in line with the screws, is to move the machine oblique to the screws. If you'll make your machine crooked, this is a great point, because when we first started, I couldn't see the screws on some of it. It's like, where'd the screw go? The screw vanishes. And it's because we're in line with the screw, with the spin. And so if you'll just go crooked to the screw, like for a transiliac transacral screw, just move the machine crooked when you spin, and then you'll get the whole screw. It'll come, your image will be you won't have this perfect axial image, but you can track your screws very well if you just come off the axis. So go just a little crooked. Don't go in line with your
That's
screws.
very helpful.
That's why you can see the sacroiliac style, the oblique screws so well. And then those ones that I revised that are going through and through, were not quite oblique enough. That's why they get a little bit of a blast effect also. So just move your machine a little bit. Yes?
That's a great tip, by the way. I have a little bit of experience with a similar machine, a different brand though. And I can concur the scatter has been a bit of an issue. But, so my question is, what is your sequence? Like, do you put in the guide wire first, then do you spin the machine, and then do you drill after, or?
I almost always, I'm really comfortable with the osteology. I make a really careful plan, as you know. And so I think that I've got about a 99% safety. I feel good. But like the guy that I saw this wire, the wire looked great at S2, but on the inlet view, it was too posterior. And the lateral was tough on this guy. And so we just spun him with the wire in because I wasn't sure it was in the right place. It looked way too posterior, and of course it was. So you say, well, why'd you even do that? I wasn't trying. I mean, I didn't get up that morning to screw up the screw, you know. But I rarely do it with the wire. Sometimes I'll clamp an acetabular fracture, and it looks really good, and I can't even believe it. And so I'll spin it with a clamp on, just to sort of make sure that the reduction is what I think it is, and we're done. You know, then I don't re-spin it after I put the plates on, you know. I'll look at it with the different views to make sure all the implants are out of joint, but I usually don't spin but one time.
And the other thing I found is that the field is smaller than your regular Xeon, right? So when you're doing the pelvic rings, it's somewhat harder to get an overall view of the overall anatomy of the ring.
I haven't had that experience with this machine. This machine gives me everything I am used to using with any other machine I've ever used. Someone else said, yes, sir.
You seem to have much better penetration through the people. Is that the flat receiver, or is it more power, or is it the software?
I don't know. I know the images are really pretty, but I don't know why.
It's the power of the generator. It's a 25 kilowatt generator, plus with it being a flat detector.
It just makes real pretty pictures. I mean, that's why I was just, Corey and I were, Corey came in just a while ago, we were just talking yesterday, it's like, oh my gosh, you know, once you see the difference, it's stunning. I think when your intraoperative films look better than your postoperative films, you've got to pay attention to that. Any other questions? Simple questions, please keep them simple. Simple questions. Okay, then I'm going to turn it back over to you, and
Well,
there's a machine here if you want to.
Yeah, so thank you so much for coming. Thank you to Dr. Routt. Let's give him a round of applause.